Welcome to this recording on implementation science. In this lecture, we will discuss implementation science, but we will focus especially on clinical audit and quality improvement techniques. So this is a lecture which is orientated at the practice. So the objectives are it's only an introduction to implementation sciences. It is also used to discuss the benefits of audit and understand the audit cycle, and to briefly also dip into other quality improvement techniques. So let us start with implementation science first. What is it and what is it good for? If you can just have a small think yourself what you understand about what implementation science is. The field of implementation science seeks to investigate and identify implementation practices of evidence-informed clinical practice, so in order to identify those practices that bring or that deliver the best outcomes for patients as well as health services. So it's implementation science is a broad term and includes all kind of techniques and aspects that look at interventions within the health services, which are aimed to improve patient outcomes, to improve cost effectiveness, to improve delivered services, to improve the work space and culture of health professionals, and therefore includes quite a lot of different techniques and interventions, techniques and contexts. So it is a heterogeneous field. But why is it important? Why are we talking about it today? So these two numbers are just examples of why it is important. Globally, 287,000 women die as a result of complications in pregnancy and childbirth each year. And 7.6 million children die of preventable diseases. So both of these numbers are extraordinary in the global context, and they should really be reduced. Implementation science is one way of looking at how can we improve outcomes, how can we improve numbers such as these. I could have taken any other numbers, looked at healthcare associated infections, at other causes of death, but it's just an example of why implementation sciences is so important, so that we keep on improving our services that we deliver. So implementation science is a systematic approach to quality improvement interventions. So it wants not just to do an intervention and run with it. No, it wants to assess the impact of the intervention. Has it delivered what was hoped, what it promised to deliver? It also is a way of sharing ideas and methods as well as results, so people can learn from each other. Different people engaging in implementation sciences can learn from each other different techniques and different ways that work for different problems. So you want to learn. Implementation sciences also wants to learn from their own and also others' successes, but also failures, because also failures are important, because we know what does not work, so we try a different way. So both successes and failures are important in this. This is a slide I just want you to have a look at. It demonstrates the conceptual model of implementation sciences or implementation research, and I want you to have a look at it to understand the importance of the context. You can see that the square around all these interventions, all these things that we do, is the context. The context is anything around that is not the intervention itself. So the location, the setting, the workforce, the resources, everything is the context. The patients, even the comorbidities of the patient, everything is the context. And therefore, I want you to realize how important the context is for implementation research. And in anything you do in implementation research, you always have to consider your context, and you always have to describe the context very well when you want to write up any piece of implementation research. So the core of implementation research is that you look at implementation strategies, you look at an intervention, you look how is it how was it before I have done the intervention? Now I have done the intervention. What kind of did change in our services? And you can see that implementation outcomes can be very different ones. They can look at feasibility, at fidelity, at penetration, meaning how many people are reached by it, at acceptability, sustainability, uptake, or costs. Okay, they can also look at service outcomes such as effectiveness, patient-centeredness, timeliness, and finally, and this is the core of the implementation sciences. In the end, implementation science wants to affect patient outcomes. So it wants to have an impact to improve patient outcomes. But the importance and the message of this slide is that you have to always consider the context that you're working in, and in any piece of implementation research you write up, you want to kind of describe this context very well. So let us now look at implementation research in practice. You have to start with planning your piece of research very well. So you want to examine strategies and interventions as part of some quality improvement efforts. So you want to look at what is it that you want to improve, or what is it that what do you want to test with your intervention? So you have to define a clear research question, and this has also got to be noted down in your paper. So you can say did hand washing or a new guideline and policy on hand washing reduce healthcare associated infections, for example, as a clear research question. And you should also always formulate a hypothesis, such as we expect that, or it is expected that the new policy on hand washing and the new the new hand washing facilities will improve hand washing practice and therefore reduce healthcare associated infections. It is always important to review the literature on the area or intervention. So you want to look at what has worked in other settings, or what did not work in other settings. Could the same work here? Could we face the same problems as other settings have done before us? So that you can use and determine a useful intervention that will give the best results. So you have to define and be very clear on your implementation strategy. So you have to define your outcome variables. How are you going to measure the outcome? How can you measure impact or efficiency of any intervention? Okay, these can include, and I've said it before, acceptability by the patients or the staff, actual adoption of any intervention, appropriateness, feasibility, fidelity. It could look at the cost and cost effectiveness, and it can also look at coverage or sustainability. It could look at a number of those outcomes as well. but it is always important to be clear on the outcome. What are you going to measure, and how are you going to know the impact and the effectiveness of your intervention? So I already talked briefly on reporting your research, and I am in favor of research that you have done, that you have spent time on and looked into. I'm in favor of actually also reporting this so that others can benefit from your experiences that you have made. So, but in order that others can benefit, you have to describe your research question. You have to describe the process or initiative or intervention that was examined. You have to describe the context. So it might be very different if you are in a low resource setting or in a high income setting. Or even within a high income setting, there are maybe such areas which are involving more deprived areas, and there are affluent areas, and this can be influence your intervention result. You should of course give detailed results, and you should then also look at what could have led to those results. Okay, so you maybe found that your hand washing policy did not improve or did not reduce healthcare associated infections. Why was this? What other factors could there be causing these infections? What factors were there that maybe uptake of the intervention wasn't good enough? And you should look at those and make draw some conclusions of those, of course, within the context of other literature as well in the field. A growing number of journals are actually interested in the field of implementation research. There are some journals specifically interested specifically for this field of research, but others also the wider, and one is the Implementation Science, is a journal called Implementation Science. Others are also interested and might be able to, might be wanting to publish any results. I feel that every effort should be made to share results and possibly publish them, either by presenting them at conferences, at national meetings, at local meetings, or by publishing them as papers in international journals. So it is important to share learning points and effective strategies, but also those failures that maybe you encountered. So let us look at one way of doing implementation research, which is clinical audit. Let us look at what is it good for and how is it done within the next coming section of this presentation. A clinical audit is a systematic process of looking at your practice and asking yourselves, what should we be doing? Are we doing it? And if not, how can we improve our current practice? These are the three questions that audit strives to look at and to answer. Audit is different from research. While research pushes frontiers and asks new questions, so wants to find new knowledge, audit builds on research. Audit uses previous research to kind of define their standard and to define the evidence. So research tells us what to do. It provides the evidence that then audit can check if we are doing it right. And so audit uses the research to know what to do and how to do it. So one way of describing it is research asks, are we singing the right song? Audit asks, are we singing this song right? This is the basic difference between audit and research. So here you can see a few more differences which are in practice also important. Research uses experimental methods such as randomized controlled trials, while audit uses comparison of current practice with best practice. Research uses a range of statistics to make inferences, while audit just uses simple descriptive statistics to describe current practice. Research can be generalized to other populations, while audit relates to the local area, to the area where the audit was carried out. Research provides evidence for clinical policies and guidelines, and audit measures how well current care conforms to clinical guidelines, policy and guidelines. So, although they are different, there's a very strong link between research and audit as well. Audit looks at the quality of care. Does it need improvement? How can it be improved? And then it checks if the improvements were effective or sufficient. The first person who was, or the person who was credited, let's put it that way, with doing the first audit was Florence Nightingale, who was a nurse in the 19th century, and she was a nurse who went to the Crimean War. When she first came to the Crimea, she was appalled by the situation she found in the local field hospitals. They were conditions that were very crowded, that were dirty and awful, actually. And 18,000 British soldiers died in the Crimea, but only 2,000 of those died on the battlefield. The rest died as a result of their wounds and usually with infections. So Florence Nightingale saw all this and made a new system within her hospital that she was in charge of. She made room for the soldiers so that there was enough room on the wards. She cleaned or put in place systems to clean the linen regularly, to clean the floors, and she actually noted down the numbers and the impact of these procedures. So she made these interventions, and she took these procedures, or she took these steps. She undertook these steps, but she also noted down how such steps, what impact they had on the morbidity and mortality of the soldiers. And these numbers she sent to Whitehall, to the British government in Whitehall, and these numbers convinced ministers to give her more money for laundry facilities and cleaning processes, and even to send more nurses to work with her in the field hospitals. So just having these numbers to show what kind of impact such simple procedures had made a big difference in her resources. So let us look at clinical audit, and let us look at the clinical audit cycle. And we are going to look at every one of these 5 steps in turn. We start with looking at planning the audit. What belongs to planning the audit? Planning the audit includes to choose a topic, define the aim of the audit, and to put down objectives for the audit. Choosing the topic is generally easy. So you would look at anything within your organization which maybe has high priority or which has a high volume of work. Maybe there's high risks attached to it or high costs. Maybe you identified patient needs for making some changes and improving some care. How do you define the aim, or what is the aim? What should the aim be of your audit? The aim identifies the overall purpose of the audit. It's important to be specific and focus on improvement of practice. For example, one aim of an audit could be to improve the care received by patients with leg ulcers. Or it could be formulated, are we meeting the standards of best practice for management of leg ulcers? And what are objectives? So objectives denote certain steps that you have to go in order to reach your aim. If you are a medical student and you want to become a doctor, then you know you have to pass the exams in surgery, medicine, pediatrics, gynecology. You have to pass all these exams to get to your aim of being a doctor. So your objective maybe in this term are to pass your exam in obstetrics and gynecology so that you reach your aim after 5 to 6 years to become a doctor. And this is also, this is what objectives are. Objectives break down the aim in achievable and measurable outcomes or questions. Okay, so was the right treatment given to the right patients? Was the treatment given at the right time? Were deteriorating patients reviewed within 15 minutes? Was this emergency cesarean section complete within 30 minutes? Was the treatment given in the right way with the desired effect? These are all examples of objectives. So another example is if we look at the topic of treatment of leg ulcers, we can put down the aim to improve the care received by patients with leg ulcers, and we can say as objectives to ensure leg ulcers are treated appropriately, to ensure timely treatment of leg ulcers. So let us go to our next circle, which is the standard selection. So first of all, we have to ask ourselves, what is a standard? What does it mean, a standard? A standard is an explicit statement describing the quality of care to be achieved. And this standard is definite and measurable. It is always based on the best available evidence. And this is how you have to select your standards. How can you identify a standard? How do you know you find the correct standard? The best way of identifying standards are always looking for guidelines and protocols, because these guidelines and protocols should be regularly updated and they should also be based on the best available evidence. However, if there's no guidelines or protocols available, then you would have to do a literature review yourself to find the best available evidence. This will be a rare situation in these days. Standards should follow the SMART abbreviation. So they should be specific, clear, and unambiguous. They should be measurable. They should be agreed by all concerned who deliver the care. They should be relevant, and they have to be theoretically sound. So they have to be based on evidence of best practice. So if we look at our previous example, we can say that the topic is leg ulcers. The aim is to improve the care received by patients with leg ulcers. The objectives are to ensure that leg ulcers are treated appropriately, to ensure timely treatment of leg ulcers. And the standard is venous leg ulcers should be treated with graduated compression stockings. A second example could be at the topic of treatment of MI. The aim is to assess compliance or adherence with guidelines on treatment of post-MI patients, on patients after myocardial infarction. The objective is to check if patients received the correct drug treatment after the myocardial infarction. Regarding this correct drug treatment, the standard is that all ST elevation patients with ST elevation myocardial infarction and those patients that have non-ST elevation myocardial infarctions have to receive quadruple treatment following their myocardial infarction. And this includes aspirin, a statin, beta blocker, and an ACE inhibitor for treatment. So this can also be an aim, the objective, and then a standard for your audit. So the next step brings us to the heart of the audit, which is measuring performance. Measuring performance includes data collection, data analysis, and presentation of data. All of this is included in this step. Data collection can either be retrospective or prospective. And I'm only going to talk about this very briefly because you might know this as well. So retrospective means you look in notes, you look at care delivered to patients in the past. So you look in notes or computer-held notes, and you see what was done in the past. Prospective means you have a question, you give a questionnaire to the caregiver, you have patient questionnaires, you observe what patients, what treatment, what patients receive at the moment, or what care is delivered to patients at the moment, or what healthcare professionals are doing at the moment. This is prospective. Retrospective and prospective data collections have advantages and disadvantages. So retrospective data collection has the big advantage that you can do it quicker. So you can look at 100 cases, 200 cases from your notes, and you can do this and be finished with this quickly. But the problem with retrospective data collection can often be that you have a lot of missing notes. Prospective data collection, on the other hand, usually you can collect all the data you need to collect, but the problem here is that it might take a much longer time because you have to wait until you get enough patients coming through your door, receiving the treatment or diagnosis that you want to investigate. Data analysis in audit is mostly simple. So usually just with a pen, paper, and calculator. Percentages, ranges, averages, and outliers are enough to kind of describe the results of audits. And you can use, of course, an Excel spreadsheet, but this is not usually necessary. The audit presentation is a very important part of your audit work. This is important because you want to feed back your results to the team so that the team knows how they are doing and they understand what are the areas we have to focus on for improving the care we deliver. So it's a crucial part. It should be a simple presentation that is easy to understand. All caregivers should be made aware of the audit findings. And the best thing are audit meetings, regular audit meetings from the whole department for this, either every month or every 2 months, every quarter of a year, that you have one meeting in which you look at 2, 3, 4 audits and look at what it means, and all the team should come to this meeting. The sample size is often discussed in this audit work. It is not the sample needs to be large enough to be representative for local practice, but it doesn't have to be an enormous sample because you're not wanting to investigate a whole population, so it needs not to be representative for a whole population. So there's also often a compromise between the sample size and the practicability. You can either look at a sample size in terms of numbers, so you want to look at 100 cases, 150 cases, or you can say you look at a time span. So you want to look at all cesarean sections performed from January to July, for example, 6 months worth of cesarean sections. This is also a way you can determine a sample size. So we come to the most important part of the audit cycle, which is the actual time of making improvements. This is also the most difficult part of the cycle. Until now, it was all in your control. You could plan your audit, set your standard, measure the performance of your team or your unit. But now making improvements, you need contributions from all of the team. You need the whole team to pull together in order to get these improvements done. And this is can be challenging. However, you should always remember that it is possible to reach this goal. It is very good to have a clinical audit hero for this, to support your work in this. This is somebody who will support your audit, who will give it a voice. So it should be somebody from higher up in the hierarchy who will give you your findings voice, who will carry it to the team and make the team understand how important it is. So this is very important and should be amongst the leadership in the health unit or in the health system. So all good audit looks at how to implement the recommendations for improvement of practice, which is the most difficult part of the cycle, the audit cycle. And it's important to get on board all professionals that are affected by your recommendations and to make one responsible for implementation. In this way, you will get the best results if you have somebody responsible for this. And I can give you some idea about how difficult this can be from audits, clinical audit work that has been done in the Gaza Strip. Audits have been done for longer in the Gaza Strip, but they have only been done to a larger number since 2015. This was a time when audit was introduced into the curriculum of one of the medical schools in the Gaza Strip, and the introduction of this content has kind of paved the way. So students were getting involved in audit and wanting help from clinical doctors in getting involved in audit. And this paved the way also for the doctors, the nurses, the health policy makers to become more interested in this technique for quality improvement. So you can see here that in 2015 there were 4 audits registered. And then you see a constant increase until 2018 when you had 24. So from these 24, from these audits, all of these audits together, you had 13 with completed audit cycles. So 13, you had complete audit cycles. And from these 13 completed audit cycles, you can see that only 7 showed improvements to practice. But the large majority of the audits, 50 of the 62 audits in total, 55 audits showed no change. So this is so just doing audits. What I'm wanting to let you to make sure you understand, just doing an audit is not enough. You want to also see the improvement in the practice connected to the audit. So you want to see that audits lead to improvements in practice. And this is the hard part, the difficult part, which people have to really put more energy and effort in. So sometimes making an action plan at the audit meeting helps, and the action plan should cover 4 or answer 4 questions. What needs to be done? How can it be done? When is it going to be done? Who is going to do it? And if you can answer all of these questions, then you're more likely to have an effective audit process. The best thing is to have one audit lead who will keep a record of all audits done and keep a record of the action plan and the answers to these questions and follow them up. So implementation can include many different things. Often these might be that you have new guidelines formulated, that you find new flowcharts or management pathways, or that you implement an education kind of process or for staff or training for staff. Finally, we come to the area of sustaining improvements, which means that once you've actually made improvements, you want to make sure that they remain there in place, the improvements. For this, you need a re-audit. So usually this is done after a time. So you have done an audit, you have put in place interventions, and then, for example, 6 months later, you do the same audit again to see if you're if you can see an improvement in your practice. So, for example, if you found in your first audit that maybe 74% of patients received quadruple therapy after myocardial infarction, after an audit, and then you put in place a system where the pharmacist maybe checks this, that patients receive it, or that you communicate better with the patient and with the primary care team. Then you do a re-audit and you find that now 85% have improved, take the treatment. So this is a good improvement, but maybe not enough. So maybe you want to do something else to get it more above 90%. So this audit is one quality improvement tool, but there are many other quality improvement tools. And I'm just wanting to and these can include run charts, Pareto charts, and methods. But I want you to, I wanted to actually look at one, which is the plan, do, study, act cycle, which is nothing else but kind of a small, more flexible audit cycle. Root cause analysis is also one important other quality improvement tool. So the plan, do, study, act cycle is similar to an audit cycle where you plan an improvement, you make an improvement, you study the effect of the improvement, and you act on what you find. So has it improved? So should we do more improvements? So this is also this is very similar to the audit cycle, but it is maybe what maybe it formalizes what we do in practice quite a lot. Okay, so maybe you find my staff does not wash the hands, so I'm going to have a meeting to remind everybody of hand washing, or I will have regular audits to check how many wash their hands, and this will make people remind people and make them engage in hand washing. So it is something similar to that, but when you do a plan, do, study, act cycle, you also study, you collect data on your results. So you do your intervention and you could collect data on the impact, the effect of the intervention. And then you analyze this data, you study the effect. So you want to see what kind of impact did it have. So in this way, you can see what works well and what does not work as well. So first, PDSA allows you to test on a small scale at first. Okay, so you start with proposals, ideas, or theories. You do one PDSA cycle, you do a second one, and you learn from the data that you receive through all of these cycles until you reach your goal, until you have the changes that result in the improvement you want to see. And here, failures are as useful as successes to see what works. You might also have multiple PDSA cycles, which are kind of done simultaneously. So you do one change, you might do 3 changes at the same time, and then you study 3 different plan, do, study, act cycles to see their impact. So all good audit needs to look at how to implement recommendations for improvement of practice. Improvement of practice is the most difficult part of the audit cycle. You should also look at other more flexible interventions that and implementation tools, such as the PDSA cycle. You should always record and share your experiences. And in order to be effective in clinical audit, also in PDSA cycles, it is also always good to make one person responsible for implementation. Thank you very much for listening to this lecture. I hope that this was a useful introduction for you into quality improvement, and that you will engage in throughout your healthcare careers in quality improvement to kind of improve services and outcomes for patients and staff. Thank you very much.